We can go ahead and get started. Welcome, everyone. I appreciate all of you attending. I'm Dr. Diane Vana, and on behalf of my collaborators, Doctors Patty Ganz and Brenna McDonald, I'd like to share with you our protocol, NRG-CC011, Cognitive Training for Cancer-Related Cognitive Impairment, a multi-center randomized controlled trial. Apologies, my computer is not advancing. Never had that happen before. Apologies. Of note, I would like to note that this research is being conducted in partnership with the Ohio State University College of Nursing and Comprehensive Cancer Center with funding from the NIH National Cancer Institute. Just a little bit of background in regards to cancer-related cognitive impairment. For many of you working in the clinics and working with survivors, you're very familiar with the symptom cancer-related cognitive impairment. It is a significant symptom our patients report. In fact, up to 75% of cancer survivors will report cognitive concerns. And for many, up to 35%, these cognitive changes will persist for months or years following treatment. Cancer-related cognitive impairment in our research has also been shown to be associated with poor outcomes, such as work-related outcomes, social relationships, health-related outcomes, and quality of life. And despite its prevalence and significant impact, there's been very little interventional research available to try to help address this potentially debilitating symptom. Currently, there are no definitive evidence-based treatments available to address cancer-related cognitive impairment in cancer survivors. In our lab, we've been using cognitive training. Cognitive training may be a viable option to address cancer-related cognitive impairment. Cognitive training is based on a cognitive rehabilitation approach, which focuses on a structured practice of cognitive tasks with the goal to improve cognitive function. The computerized program that we've been using in our lab was developed by neuropsychologists and is based on the theory of neuroplasticity, or really the brain's ability to form and reorganize synaptic connections, which may also increase brain activation and ultimately improve cognitive function. This program has shown some promise, specifically in non-cancer populations. In fact, there was a large NIH trial called the ACTIVE trial, which was the advanced cognitive training in the vital elderly. That trial was really designed to see if it could stave off cognitive decline. And one issue with that trial is they didn't include any cancer survivors. So in a series of pilot studies, our lab chose to look at the efficacy or whether cognitive training can be effective for improving cognitive function. In our first pilot study, we had 82 breast cancer survivors that were randomized to either the computerized cognitive training program or a waitlist control. And we brought all our patients into the clinic and had them do 10 hours of training. What we found is that the group that had the cognitive training had moderate to large effect sizes in improving their immediate memory and processing speed on neuropsychological tests, as well as we saw immediately improvement in perceived cognitive function and other symptoms that correlate with cognitive impairment. We noted this immediately post-treatment, as well as those gains were sustained 2 months later. So that really showed us a signal that potentially cognitive training would be a vital option for our patients. So in our next pilot study, we were very concerned that if this program would be viable, it would need to be able to be used in the home by the participants. And so we conducted another pilot trial to look at its acceptability and whether it would improve cognitive impairment again. And we had 50 breast cancer survivors that were randomized to the cognitive training program or an active attention control, which were really just computerized games, not based on the theory of neuroplasticity. And we asked them to complete 40 hours of training in their home. These participants rated the program very highly. 95% identified that they would likely or highly likely to use the program again. 89% identified that they were very satisfied with the program, and 96 identified that it wasn't too difficult to use, which is really important when you're looking at trying to implement a computerized cognitive training program in the home for patients with cognitive concerns. We were also able to show in that small sample a signal that it improved cognitive concerns in relationship to workability and health perception. So the next logical step is really to conduct the largest clinical trial looking at cognitive training to address cognitive impairment. And so that is the purpose of this protocol. It is a 2-group, double-mass, randomized controlled trial to conduct the very first full-scale efficacy trial to compare this cognitive training, again, that was developed and based on the theory of neuroplasticity, compared to a computerized active program that really is just games and global stimulation, and whether it improves both cognitive outcomes as well as behavioral outcomes for our patients. The primary objective then for this protocol will be to see if the computerized cognitive training compared to that attention control will impact perceived cognitive function post-intervention. The secondary aims will be to see whether or not we can sustain that improvement. So we'll be looking at perceived cognitive function, both the individual PCI scores, as well as the total score over time, over the trajectory of the trial. We will also look at objectively measured cognitive performance to see if there's any improvement on neuropsychological exam, and we will do that post-intervention, but also over time. The third aim, an exploratory aim that we believe that's very important to our patients, is whether or not this will be efficacious in relationship to real-world everyday outcomes, such as some of those that I tested before. Does it help improve work-related outcomes, workability, work productivity, other health-related outcomes, and compare the program to the attention control, both immediately post as well as over time. The methods of the study then, this is a double-masked randomized controlled trial, meaning that the participant won't know exactly what group they're assigned to, as well as we will have people that are doing the assessment that will be blinded to which group patients were assigned. Our goal is to recruit 386 breast cancer survivors. Patients that come into your clinic, we will ask you to consent them. We will conduct the baseline assessments through OSU, and then once they are completed that, we will have them randomized into 1 or 2 groups, the cognitive training program or the attention control, and we will follow these patients and multiple follow-up assessments, 12 weeks post-randomization or immediately after the program is completed, and 24-week as well as 36 weeks post-randomization. We will be asking these participants to complete 40 hours of training over the 10 weeks, which is only 4 hours per week. As you can see from the methods here, we will have participants screened for eligibility, and I'll talk a little bit more about that in a minute. And we will complete the questionnaires and the neuropsychological assessments before they ever enter the intervention. So we will have their baseline. We will run the program over a 10-week window and complete the follow-up or time 2 right at 12 weeks. So we will be collecting the same questionnaires and the neuropsychological assessments a total of 4 times over the length of the study. The assessments, as I indicated, would include patient-reported concerns and outcomes, as well as the neuropsychological assessments. Just a little note about the cognitive training program. Cognitive training program, as I said, was based on the theory of neuroplasticity. This will all be delivered remotely from OSU, so the sites will not have to be engaged with it, but just a little bit of information and background. Again, the computerized cognitive training program is based on the principles of neuroplasticity. in that its visual stimuli will increase over time. It's progressively increases in speed and processing. There's a cognitive demand that's tailored to the ability of the participants, so they don't. So we're asking them to work, but not making them too frustrated in completing the overall program. It relies on directed attention, and there's feedback and rewards throughout the program. So again, this is to engage them in completing the 40 hours of training. The attention control group will also be asked to complete 40 hours, and this is very much a game kind of cognitive stimulation program, but it does not engage them. It's not tailored to their abilities. It does not provide that directed attention. And the only feedback or reward they would get would be that of completing the global game. So you can see that there are differences. The participants will not be aware of which group that they're assigned. They both will receive 40 hours of computerized cognitive training. Again, this will be delivered remotely, and the training will be done through Ohio State University. For the data collection, we've also, in designing this study, we know how busy the clinics are. So we will be collecting the patient-reported outcomes through the Vision Tree system. So we'll be doing that remotely. And the neuropsychological assessments will also be administered remotely from the Ohio State University. This hopefully will reduce the burden for both the patient, because they can be doing this within their home, as well as for the clinics and the demand that in relationship to the trial. For the eligibility criteria, our goal is really to recruit breast cancer survivors with substantial cognitive, cancer-related cognitive impairment. We're going to ask you that you review your patients and determine that they're 18 years of age and older, that this is their first time diagnosis of non-metastatic breast cancer, stage 1 to 3, that these breast cancer patients are 6 months to 5 years post-treatment, and that's completion of initial surgery, adjuvant chemotherapy, or radiation therapy. We will include, so except for those that are on endocrine therapy or HER2 new directed adjuvant therapy, they will be able to participate in the study. The participants must also be able to understand, speak, read, and write in English and Spanish. This will be offered in both. And there's an assessment that we'll ask that you complete so that we identify substantial self-reported cognitive concerns. The ineligibility criteria and review of the medical record. Again, we're looking at early stage disease in this first trial. We're making sure that there's no evidence of metastatic disease. We're looking at patients that we're going to exclude patients that have prior history of past or current other cancers, except for non-melanoma skin and cervical cancer within the past 5 years. Previous exposure to chemotherapy treatment for another cancer or due to another medical condition, previous CNS radiation, intrathecal therapy, or CNS-involved surgery, a history of stroke, traumatic brain injury, brain surgery, or Alzheimer's disease or other dementia. And all of these are so that we're really focusing in on those patients that have cognitive concerns, but that we can really help through this type of training program. We're going to also exclude those that have active substance abuse and or treatment for substance abuse or history of other diagnosis, psychosis, schizophrenia, ADHD, or a learning disability. We also are going to make sure that they're not enrolled in other therapeutic trials or quality of life trials that would confound some of our outcomes. And there's also a screening that many of you might already do in your clinics where we'll screen out those for significant MCI or dementia, as well as current major depression. So for the sites, we really are recruiting the stage. This is a summary overview of the role of how the sites will be engaged. We are recruiting stage 1 to 3 non-metastatic breast cancer survivors. We are going to ask that you register the patients. Once you complete the medical review, record review, you'll be able to identify those that have some concerns of cognitive impairment, and then we're going to ask that you verbally consent them to do the other screening in relationship to substantial cognitive function, MCI, and depression. You will then, once determine that they're eligible, consent them, and then the baseline assessment and all other assessments will be conducted by OSU. Once the baseline assessment is completed, we will be able to notify you so that you can randomize them. And then we will be responsible for putting them onto one arm 1 or 2 of the trial. So again, the site's responsibility is in registration will be to review the medical records, identify participants eligible for the screening, obtain verbal consent to administer the screening assessment, and administer that screening assessment. We do have scripts available. There are 3 very short, brief assessments. They total 12 questions in total. Some of them you're very familiar with, like the PHQ and the 6-item cognitive screen. Note that we are asking that you, when you screen them, that you will register them in open. We ask that you obtain their informed consent. And then there will be a REDCap survey that you will complete to send their contact information securely to OSU to do all of the follow-up for the study. Again, we developed this study with the sites in mind to reduce the burden. After registration, the sites will not have to be involved with the baseline assessment. That will be conducted by OSU, and we'll notify you then when they have been completed so that you will randomize them in the system, and then OSU will be responsible for putting them on to one arm or other of the trial. In the randomization, you complete the randomization in open. And after randomization, there is one form that we are asking you to complete, which is the Cancer and Diagnosis Treatment folder. It's a very brief folder of breast cancer characteristics and therapy. All other trial activities will be completed by OSU. So this is a summary of the forms that will be completed and be available to you. The screening assessment, again, the consent form, a participant contact information link that will link the patient information to us so we can contact them to schedule the baseline assessment. There's an eligibility checklist, and then after randomization, the cancer diagnosis and treatment folder. Overall, though, the goals of this study is this will be the largest double-mass randomized control trial to test cognitive training for this important symptom. Our goal, again, is to recruit 386 breast cancer survivors across the U.S. We are looking at the goal to recruit 8 to 10 participants per month. We recognize that might be slower in the beginning as people get used to the study. But again, this will be the largest study, and it's designed to look at whether cognitive training can improve self-reported cognitive function, cognitive performance, and again, have an impact on those real-world outcomes, including workability, physical function, and quality of life. We believe in the development of this trial that we've addressed many limitations of previous work in that we will be able to deliver this remotely in the convenience of the participant's own home. We'll be able to offer it in English and Spanish to reduce barriers of participants that are commonly barriers for patients to participate in trials. And we really developed this in a manner in which our goal was to reduce any burden on the clinical sites, that the majority of the trial will be conducted and managed outside of the individual clinics. Findings for this randomized control trial will provide the evidence needed to improve evidence-based treatment for cancer-related cognitive impairment. And at this point, I'm going to stop sharing and open it up to questions. I do have my collaborators online, Dr. Patty Ganz And Dr. Brandon McDonald, if you have questions for any one of us, please go ahead and
And I see a question from Marcy. Marcy, do you just want to go ahead and unmute yourself? You're able to.
Can you hear me?
Yes.
Okay. I was wondering if the sites are going to have very little contact with the patients after the initial randomization step. If the patient wants to do the quality of life questionnaires on paper instead of vision tree, how would that be accomplished?
Yes, when we reach out to them with the baseline assessment, we're going to offer whether they want this in vision tree or if they would rather have a paper copy. And OSU will be responsible, the research staff will be responsible for doing that mail outs. And then whether and if they want that, they have the option at any stage to have this on paper form versus doing it through the PROs. And then it will be a mail back, a stamped address mailer that comes back to OSU, and we will put the data into the system for them. So thank you for that
Great,
question.
thank you.
Yep. We're trying to make it as easy as possible for the participants to be engaged in this study. And so I appreciate that question. I also should mention that for those that don't have a computer or really good stable internet access, because we are funded by the NIH NCI, we did write into that so that we could provide that for them. We could provide a computer for them and a hotspot so that they could participate. Again, our goal is to have significant reach to participants across the United States. We're very excited about this trial, and I don't know if Patty wants to say anything as well, but this has been something that we've worked on for years to try to bring a trial that would, of this scope and magnitude, that may impact and improve this important symptom.
I just wanted to add that often this is not something patients will offer up. It's a little bit like sexual difficulties. It's a don't ask, don't tell situation. And so there is an opportunity when you're seeing people back 1, 2, 3 years afterwards, and really you should be doing what we think of as a survivorship visit. It's important to ask not only about their mental health, but whether they're having any cognitive difficulties. And if they are, this is at least something you can offer them. I think sometimes as medical oncologists and clinicians, we don't like to ask about something if we don't have something to offer them. But because you now do have something that they're potentially eligible for, and that is very conveniently designed in terms of the trial, you've got a reason to ask that question. I think also, while we're so much more used to recruiting people as they come into the clinic, so they have a new diagnosis of breast cancer or colon cancer or lung cancer, and we look at what trials we have to offer, these have to be post-treatment patients who are coming back and follow up less frequently. So one strategy would be, when those patients come in, to make sure that you bring this up as a potential opportunity. But there is the possibility of you going back through the records of your clinic patients and seeing patients who would meet the medical eligibility, and then perhaps sending them an email through your electronic system or contacting them by phone and letting them know that you have a new trial that's open. Are they having any difficulties? So I think there are a number of strategies that can be used to identify these patients.
Thank you, Patty. I think and Erica wanted to reiterate, there will be an in-person workshop for this trial at the NRG meeting in Orlando, Friday, February 16th from 8:30 to 10. And we'll be able to really go over all the forms, all of the things that, that go along with like implementing the larger trial. Again, we were trying to be very thoughtful about how to deliver this, that it would be user-friendly and acceptable to the participants, but also to your very busy clinics, and making sure this was not too much of an added burden, because we know how busy the clinics are. Don't know if Brenna McDonald wanted to add anything. If you wanted to add anything, Brenna, from your perspective.
No, I think you covered everything. I did, obviously, like you mentioned, we've been trying to get this work funded for a long, long time. So we're just very excited to get it going.
Yeah. And we really have to thank everyone at NRG and all the work, that's been done to turn an R01 into the protocol has been just wonderful support from NRG Oncology to help make that happen. And we wouldn't be here if they weren't so supportive. Again, and if you have any questions even before the February workshop, please don't hesitate to reach out to me. bana.1@osu.edu. I'd be happy to have any conversations in regards to the trial, questions, concerns, because we want to make sure that this moves forward, and and your feedback would be integral to making that happen.
I think also, while this is obviously an NCORE activity, it will be open to sites that are just part of the NCTN, not part of the NCORE. So those sites that see a lot of breast cancer patients, again, important to promote this as well.
Yeah.
We think that this is again a hidden problem that many people are not paying attention to as they see patients in follow-up. And patients will be very appreciative of at least having it mentioned. And sometimes they're reassured if you screen them and they don't have a score that gets them into the study. That's also good. So valuable interaction.
Further questions that we may answer for you today? If not, I just want to reiterate that we're very open. Please don't hesitate in contacting us in regards to the trial. We're incredibly excited about it opening. So you'll be seeing more information and obviously through the workshop in February.
And Erica, do you know when the protocol might be activated? I know we put in a recent amendment, but so it will probably certainly be available after the first of the year, but maybe Erica has better information.
Yes, we're hoping January, and we're definitely hoping by the meeting. As we just kind of at the hands of DCP and the CRB right now. So
Yeah. Yeah.
And we do have recruitment brochures and other materials that have been approved, so that again, those could be mailed to patients or be available in the clinic.
Yes, that's a good point. All of our resources will be posted and available for you. So to make it very easily for you to access as you normally do, and then be able to disseminate this to a large population of breast cancer survivors. I know Brenna and I both have done these kinds of randomized trials before, and there are many people out there suffering that are looking for, support, help, want to be engaged in this treatment, whether or not it would help them directly or not. They've been very engaged. We've had patient advocates that have helped us along the way in developing this, which we really appreciate. And so if there's any questions or concerns, please don't hesitate in letting us know. Well, with that, I thank you again for your time and attention to this important topic, and we are open to further discussion. We're looking forward to opening hopefully in January. Thank you so much for your time.
Thank you.
thank you.